I tell students all the time, that we don't appear to be a religious country when you measure religiosity, but there are two things we have great passion for. They both start with H. This week you can watch 40 hours of hockey on television. It's not a great surprise that the national news gets bumped to between period snippets for a period of almost 3 months. And that the whole country engages, at least at this time of year, in a bit of a religious frenzy. The other H, of course, is healthcare, where we've got huge passion. As Ellen Gregas said, it almost is part of the definition we feel as Canadians. It's not coincidental that perhaps in an imperfect poll, the process may have been imperfect, but the greatest Canadian as determined by Canadians was in fact the Premier who introduced Medicare into this country and hospital insurance, Tommy Douglas. So the passions are very intense. The vehicles, often I think the intensity for healthcare makes it almost difficult to have a legitimate discourse about its strengths and weaknesses. And often, I think we're left choosing sides in a debate that actually needs to find much more middle ground. I think in an interesting way, there's a sense of deprivation in the health community because of the non-2014 Health Accord. The fact that there is no likely to be much discussion or debate around an accord, I think, has really disarmed a huge number of our national organizations who are all gearing up for a real debate once again about the future of healthcare in this country. And I think there is a sense of deprivation that we won't have the opportunity. So it's with great pleasure that I start this morning by introducing Don Drummond, who is currently an adjunct professor and the Matthews Fellow on Global Public Policy at Queen's University. In 2011-12, he also served as chair, Commission on the Reform of Ontario Public Services. The Commission was tasked with advising the Ontario government on how to balance its fiscal books while improving the value for money for taxpayers' dollars. From 2000 to 2010, he was the chief economist and senior vice president of TD Bank and led TD Economic Studies in the Canadian, U.S., and international economies while continuing to conduct studies of public policy. Ladies and gentlemen, Don Drummond.
Oh, thank you, Brian. Good morning to everybody. So we'll start off on a little light note with The Economist. I got to say something about this building, though. You look at that screen up there, you got Dean, Faculty of Medicine, you got National Public Health Reporter, Premier Saskatchewan, for me, Economist. It kind of just brings you down with a thud to begin, doesn't it? We'll see if we can't lift that up a little bit. So, not being immersed in healthcare before, I kind of look at it from a detached economist perspective, and people in your, some of you connected with medical sciences call economists cold-hearted. I would say no-hearted, so it's very easy for us to look at that from an objective fashion. And I would say, talking to most stakeholders in healthcare, they got a pretty good idea where they want it to go, and you have to observe it's not going there. And they've had a pretty good idea for a long time where they want to go. It's not going there. So I think you got to sit back a little bit and be a student of history and figure out why didn't it get there. And as in most things in public policy domain, you start off with why do you want to reform it? Why do you want to change it? And I don't think we've ever clearly defined that, and I think that's part of our problem, or even really understood it. Much of the discussion around healthcare comes around this word sustainability, and I think that's largely a waste of time pursuing that, because sustainability is in the eye of the beholder. Anything sustainable, depending on the degree to which you're willing to squeeze out other public services and or increase taxes, and there's no definitive answer on that. So the definition of sustainability seems to be right now as whether it's growing faster or slower than the nominal size of the economy. So if we pick an economist terms, the gross domestic product, if it's growing at 4%, healthcare is not sustainable, it's growing faster than that. And that's nonsense, and I think trying to get that kind of precision has been a false start and confused the debate. So in almost all the provinces in Canada and at the federal level as well, the last 10 years, healthcare spending has been increasing between 6.5% and 7.5%. So that in most jurisdictions has been well above the gross domestic product, and to some degree it has squeezed out other services. It hasn't in most jurisdictions required anybody to pay taxes. So can you actually sit there and say that's unsustainable? I would say not necessarily. I think something does have to change on the financial system, but you can't be quite that precise about it. I would think in my crystal ball over the next 10 years that the growth in the nominal income in Canada will be somewhere around 4%. You can determine fairly accurately the growth in the labor force will be somewhere around 0.75%. And you have to have a little footnote beside that. The entire 0.75% is coming from immigration. And certainly in the last decade, immigrants are earning way less than the Canadian born. So that's not creating a commensurate increase in income. So you have to have a little bit of a qualification even around that labor force growth. The productivity growth in Canada over the last 10 years has been well below 1%. And even if you remove the terrible years connected with the recession, it's still below 1%. But governments, to their credit, federally and provincially, have done a lot of good things that should bolster productivity. Probably the most dramatic is they revolutionize how we tax capital in Canada. We used to have one of the highest rates of taxation of capital. Now we're well below the US and towards the lower end of the international scene. We've had lots of public sector infrastructure spending. We've had quite an increase in business investment spending as well. So let's say productivity grows at 1.25%. So 0.75% labor force, 1.25% on the productivity growth. That would give you 2% real growth. And I suspect we'll see a continuation of the rollovers of the current agreement between the federal government and the Bank of Canada at 2% inflation. So 2 plus 2 gives you 4% nominal income growth. So what should and what is affordable in healthcare beyond that? And as I said, people are searching for a definitive answer when there is none. There has never been a poll done anywhere in Canada that healthcare has not been the #1 concern and interest of people. There's never been a poll that says there's an additional dollar of resources available to allocate. Where would you want them have them allocated? They will always say on the healthcare. So if a duly elected Democratic government was going to allocate spending, they would obviously skew it towards healthcare. That's what people want. And it is a unique field. In most other fields, technology gives you opportunities to reduce costs. It doesn't by itself in healthcare. In fact, technology usually drives up your costs because it increases the range of operations that you can do. We didn't have artificial knees and hips and the like before, and we're constantly getting medication breakthroughs that will increase costs. And you can adjust systems to try to get some of the efficiency gains from them, but more or less, they tend to drive up your costs or they drive it down before. We have the benefit of the United States, of course, having been around and having statistical agencies for a long time. We can observe the long-run pattern, and we do observe that for every 1% increase in income in the United States, and this is going back over 100 years, healthcare goes up by 1.6%. So if you do the math from that, 4% nominal growth would suggest 6.4% is a normal pattern for increases in health, at least according to the US definition. So I think we should de-emphasize that a little bit, and yes, we cannot in that environment of 4% growth have healthcare spending at 5 to 7%, but to me it suggests that one of the difficulties of the debate is we've attached it too much around the financial parameters. That's an element of it, and of course that comes more to the fore when jurisdictions get into fiscal difficulty, as most of them, certainly Ontario and Quebec are at the moment, and they fade a little bit. I think the more telling one why you want to reform it is for the money we're spending, we're not getting a great system. And this will come to one of the obstacles too. That's not generally recognized. The public does not accept that. They do not understand that. And of course, what government wants to go out and say, I'm not delivering a great system. But we did spend $192 billion on healthcare last year, and we're 11.6% of our GDP. And if we put the United States aside for a moment, and we should, because they're the absolute worst, so beating them is like winning a 100-meter race when everybody else is going backwards. Now, that's not a real big thrill. So, there's a small group of countries that are right around that 11.6%. So when we're basically tied with a few others as the second most expensive healthcare jurisdiction in the world. And yet our results are relatively mediocre. We do reasonably well. So if you get some of the types of cancer, we do well, but we do poorly in others. We have one of the highest rates of hospitalization for adult diabetes, childhood illnesses, illnesses that can be avoided, deaths that could be avoided. We don't do particularly well. And of course, everybody has some degree of rationalization, but we have a huge degree of rationalization, very long waits in some jurisdictions to get in to see a general practitioner, one of the longest sets of waits to get into specialists in the world, despite spending all this kind of money. I would say the second aspect too, which flies in the face of the public's understanding of our healthcare system, is we pride ourselves on having a public sector healthcare system, and we don't. In fact, we're at the low end of the range of that. So we have, of that $192 billion, 70.6% of that's in the public and almost 30% is in the private sector. Most of the other countries in that nexus of the OECD are in the high 70s or the low 80s. So we're not particularly public sector. And then to take it further than that, we have a very odd and unique structure in which we're almost 100% public and primary, but for example, 46% in pharmaceuticals and less than 10% in everything else, including almost all aspects of mental health. Most other jurisdictions are much more even than that. They will have some system of co-payments or a public insurance system that will cover a much broader array. And that shows up again in the quality of it. So I think one result that stunned some people was the survey that was done by the Canadian Medical Association last year that said 13% of Canadians had not filled the prescription given them by a doctor over the past 12 months due to financial constraints. And I think as you presented that to Canadians with this pride that we run a public healthcare system, that would shock them and say, well, that's the United States, that's not Canada. But no, that is Canada. So I would think, yes, there's a financial element to why I want to reform it, but I think there's also a quality element that it should be improved for the kind of money that we're already spending. And I think there's an access and an evenness problem of that. And as we see the income distribution pull apart, and we're seeing that, it's always presented to us the top versus the very bottom, but what you're beginning to see in Canada, as we've been seeing in the United States in the last 10 years, is a collapse, a total gutting of the middle income job, certainly of the middle income job from the blue collar work. And it's not just the low wages in China. I mean, you're seeing the base wage for that kind of work in the United States go to $15 to $17 an hour with no benefits. And unfortunately, that will be coming to Canada fairly soon. So these issues will come more to the fore. So there's much more at play. I think we have to be clear on our objectives. And that comes to, if a student of the history of this, you have to analyze, well, why hasn't the reform come? And part of it's because we're not honest to ourselves. Again, we run an image of a healthcare system that's not true to the reality of what we have, and there's nobody that's telling people otherwise. And I can completely understand why a government won't want to do it, because it'll come back, you're admitting your own failure, and we have not typically had stakeholders do that. And again, we run into a relatively odd structure we have in Canada with our federalism scene. With healthcare has never been de facto in the federal regime, but it was very involved, and we have a government at the moment that seems to want nothing to do with that, and people lament we can't get anywhere, and I just say get over it, it is what it is. That doesn't mean it have to stop it. We are, I think, in an odd point of the federalism as the federal government. Well, historically, anything that was national in Canada was by definition federal, and now as the federal government increasingly is not involved in that, and you can go through the long list, affordable housing and labor market policies, it falls on the provinces, but the provinces don't tend to do a lot together. So they dealt effectively and fairly quickly with tainted blood, but and they talked about a year ago establishing a national drug purchasing agency, because I find it's a strange term. It makes me think they're going to build a warehouse somewhere and store all these drugs. I think what they mean is establish a base price that you can enter into, but not that much is happening on that. So it tends to be each jurisdiction on itself, and again, well, that's what it is. Get over it with it. I'm somewhat surprised the provinces don't do more in a collaborative. I would want to do that for the sake of cover. For example, if you're going to delist something in a province, I would feel a lot better if 9 other provinces have done it than I'm doing it on my own. But again, such is life, and it's a big portion of everybody's budget, so they need to get onto it. So after looking at that, I mean, it's basically, it's an economist environment scan looking at this picture that a lot of really informed people have got a pretty good idea where they want to take the system, and not much is happening to get it. And there's obstacles, and you see the obstacles in history. How do you break it? And my conclusion from that is it'll only be break-in if the role of the stakeholders changes. how many times have we seen the statement that we cannot have an adult discussion about healthcare in Canada? And I find that the people who do that expression themselves are very juvenile, because implicit in their message is they bemoan the fact that governments do not lead it. And again, it is what it is, and they're not going to do it. I had one little element with André a little while ago, because I had on a number of occasions used what I thought was the Joey Smallwood quote, that I've never said anything about healthcare that hasn't cost me votes. And at some point I was actually going to put it in writing, and I thought I'd better find the source, and I could never find the source. And I laughed my head off about a week ago after that. You wrote an article saying that everybody says this, and it's become an urban legend, but I couldn't find the source of it. So maybe Joey never did say it, but if he didn't say it, he should have said it, and any other politician should say it. So my view is we were going to get meaning healthcare when the stakeholders have created ideas for the reform, had some degree of consensus. It'll never be perfectly across the various different stakeholders, but some degree of consensus. Will do communications to the public, and then here's where it takes them out of their historical element. They will do some conditioning of the public. I mean, the number one rule in public policy is the first time somebody hears about a change, they revolt. They always react negatively, and the 100th time they hear about it, they're just bored silly by it, and it just slips in. So the classic example of that, you just look in Ontario, 2003, the government ran, they was going to do some public-private partnerships on hospitals. All hell broke loose. 27 of them have been done since. There's not a word about it. I mean, in part, they were genius. They changed. They don't call them P3s anymore. They call them alternative financing, and nobody knows what that means. And then, so like these things can be done, but somebody is going to have to clear out the turbulence, and when that is done, the governments will poke their heads out of the bunker, and they'll follow into the wake that somebody else has created. So we got to come back how to get those conditions. And on that front, I'm quite encouraged. And that's an element where I think that this financial squeeze could actually help, because I think a number of the stakeholders realize something is going to happen to them. They too are students of the history, and as a public policy person, you cherish what happened in the 1990s. My greatest lament as somebody involved in public policy is no one will allow me to conduct experiments on the citizens of and I feel that's unfair to economists, because biologists and chemists and physicists are allowed to construct experiments, and we're not allowed to do that. And there's a great fear we're going to ruin people's lives. So all we're constrained to do is look at the history of experience. And we had a wonderful experiment in the 1990s where every government, and it varied between 2 to 5 years, slammed the brakes on the healthcare. Some of them kept it to modest increases. Some of them actually cut the level. And in all jurisdictions, it created problems. There was perceptions, if not realities, of blows to the quality of the system within a couple of years. Again, I'm sorry if I give my examples of Ontario, but I understand I've been immersed in Ontario, particularly healthcare, for the last year. So it goes 3 consecutive years of almost no increase, the 4th year 11.4%, and almost everybody did that. So really nothing was accomplished from that. So again, you got to look at that lesson of history and figure you got to do it differently. And the common fault is that most of the jurisdictions didn't do the underlying reform. They just simply took the money out of it. And I think we got enough evidence that that doesn't work. So how do you get the meaningful reform? And again, it comes back to you have to create that kind of consensus. Have those ideas put out by people who are not directly connected to the government, because they're not going to lead on that, and have some degree of acceptance. And I think there's a lot of ways you can do it. We have never been comfortable, and we've never applied, it sounds like a dirty word this day, but sort of a business or efficiency lens to healthcare, because it's so sensitive and it's so important to people. And I said, well, but that's not an excuse for not applying that. And the classic opportunity, I think, in the healthcare is you can, in making it more efficient, you can actually improve the quality of it. So I think every time I've done any kind of report, there's always one statistic that stays in your mind. And for me, it first came to us as 1% of the residents of Ontario account for 49% of all the hospital spending. And then ICES converted that to the total health care. It was 1% of the Ontario population accounts for 34% of the healthcare spending. So again, coming back to the international, 99% of us are really cheap to look after. 1% is really expensive. And everything in life is skewed, so it's not surprising you get a high number. But then you look at the experience of that, and you realize that the inefficiency with which the 1% is dealt with is causing serious problems in their life. So somebody with congestive heart failure is in the hospital, they get discharged. The hospital doesn't have electronic discharge, so the physician doesn't know that they're discharged. Most of the doctors, certainly the ones in GTA, long ago gave up their hospital privileges, so it's not like they're going to be walking down the hospital corridor and notice their patient's gone. We know from pilot tests that if somebody with congestive heart failure is visited by a nurse within 48 hours, their chances of being readmitted are reduced by 1/3. But the community association is not notified even within that 48 window. So something goes wrong, the person's back to hospital, and you just create this do loop of just out and back and out, and that's not doing them any good. And again, we come back, we have the highest rate of hospitalization for people with type 2 adult diabetes. We have the lowest rate in the OECD for people with type 2 adult diabetes taking the 3 standard tests. Obviously, they're related, and so that's very expensive, but it's deteriorating the quality. So I think we need to see the doctors and the nurses and all the other stakeholders, and it's becoming, the CMA put out together some very sensible suggestions. The Nurses Association and the national and the provincial have made some very sensible suggestions. I'm really quite taken back. Some of the CEOs of the pharmaceutical companies have made some suggestions on pharmaceutical use that actually presumably lower their revenues, but such as it is, they've tabled that. So I think that the stars are going to crash on this thing, but they're going to crash a little bit less lately. So I'm just going to end up, there's a role on the technology front, in fact, a huge role. So I think to Canadians' pride, we're probably the most advanced in telehealth, and maybe that's just exploiting a national need because of our large distances. I think we're in pretty good shape on the digitization of diagnostic, although I'm now in my 3rd week of trying to get an X-ray on a CD, so I'll come back on that one later, how advanced. The digitization, it was fine. What to do with it seems to be a little bit of a problem. But we're slow on the electronic in the physician offices, and the management of that, and the pharmaceuticals. I mean, the other staggering statistics was if you take the number of prescriptions in Ontario, excluding refills, it comes out to an average of 10 per person. How do you get that? That's because they came from 4 or 5 physicians and no one had an idea. And we've all had the experience. You go in an elderly person's medical chest, they got 15, take them to the doctor and say, well, 15 was obviously prescribed to get rid of the side effects of 1, 14 is to balance 2, 13 is to balance 3. Again, if we had the electronic records on that. And my final word is, again, you got to be really practical on this stuff. So we're putting the big emphasis, again, sorry to Ontario example, the family health teams, get them onto the electronic era. They're given a choice of 21 pieces of software. They have no idea how to do it. Someone has to give them on a silver platter a module. Here's how you do it. You plug this in a computer and it's done. They're physicians. This is not what they want to do. They don't want to spend their lives doing IT. And the concept is there, but it's still not quite consumer friendly enough. So let's see the stakeholders rise up, play their role. You people are stakeholders, and the electronic information has a huge part of solving this dual problem of how we can increase efficiency but also slow the rate of increases. Thank you very much.
Thank you. It's now a great pleasure to introduce André Picard as one of Canada's top health and public policy observers and commentators, currently the public health reporter at the Globe and Mail. He's been a staff writer there since 1987. He's also the author of 3 books, has received much acclaim for his writing and for his dedication to improving health care. In 2010, he was awarded the National Newspaper Award as Canada's top newspaper columnist. André Picard.
Thanks, Brian. It's quite daunting to be part of such a stellar panel. Don Drummond has his own hashtag on Twitter. That's very impressive for me, being a Twitter addict. I didn't know that. You do. And Premier Wall heads the province, which I think has arguably the best healthcare system in the country right now. I think Alberta used to have it, but Saskatchewan has the crown. And why are they the best? Because they're the most... Yeah. Off the record, off the record. But why is it the best? I think it's the best because it's the most innovative and it's the most pragmatic, which are both good traits, and they get bonus points because I'm pretty sure it's the only province that has a balanced budget these days, so bonus points for that. But somebody has to be here to represent the views of the unwashed masses, so that's going to be me. So I want to take the time I have this morning, and I promised that I would take 16 minutes, so I will. I want to take the time I have to muse a bit about some of the disconnects in healthcare. You heard some of them in Don Drummond's talk, but I want to talk about them more generally. And this is all from the perspective of a layperson who probably spends a little bit too much time in the health system. So we have a population, we talk about sickness and healthcare all the time in our group, but we have a population that's generally very healthy and very long-lived. 99% of us, as you heard, cost very little. Our focus should be on giving them the tools to remain healthy. In other words, good primary care and an emphasis on health promotion and prevention. Both primary prevention and secondary prevention we don't pay enough attention to. Once you're sick, how do you prevent people from getting sicker? But we have this health delivery system, a sickness care system, and a public insurance system that's designed to provide and pay for something quite different. It's designed for acute care. And often irrationally so, the way it pays and provides. The reason we have this system is historic. Our system was built in the 1950s, and we have to look at what society looked like in the 1950s. When Medicare was born, around 1957 federally, the median age in Canada was 27. The life expectancy was about 67, so pensions were meant to be a rarity, not a normalcy. Long-term survival with chronic conditions like cancer and heart failure, diabetes were very unusual, almost unheard of at the time. So flash forward to 2012, to today. The average age today in Canada is 47. We're an old country. Our life expectancy is 82 on average. Living with a chronic illness is the norm now in our society. 80% of people over the age of 65 have at least one chronic condition. 1 in 4 seniors have 4 or more chronic conditions. I'm describing my parents. But this isn't strictly an issue of aging. We make that mistake of blaming the elderly. 1 in 4 people under the age of 24 also have a chronic illness. They're the 1%ers. And I stress too that all these people are living. They're living for a long time with their conditions, and they're living well. They're not debilitating for the most part. They should be active members of our society. That's what the goal of our health system should be, to help them remain as healthy as they can. But we have a system that's designed just waiting for them to get sick, almost encouraging them to do so. It's a tertiary care system designed to provide care in an institutional setting, the most expensive imaginable. So first and foremost, I think we need to turn the system on its head, to make it more responsive to the public we have now, to make the focus primary care and community-based care. We also have to ensure that every Canadian has a medical home, a starting point where they go for wellness advice, treatment, and then referral to the acute care when they do need it. And when they do need that care, they should be getting it more often than not where they want to get it, which is in the community, in their homes. And we have all the ability, the technology to do this. But the fundamental disconnect I see, number one, is that we're trying to deliver this 21st century care with a 1950s model. So what does all this have to do with health technology, with Infoway? Well, for me, the failure to embrace health technology is symbolic of how the health system is stuck in the past. And, we continue to cling rather pathetically to this outdated model. But maybe I should rephrase that statement a little bit. We do embrace a lot of technology, but I'm not sure we embrace the right kind and in the right place. And we don't always make that distinction. Now, I'm a reporter. I get pitches all the time, dozens a day, and I always hear about amazing new technological advances in machinery and systems, etc. Recently, I went and watched a surgeon perform a robotic prostatectomy. It was like watching my kids play video games. The patient was over there, the doctor was here doing all this. It was neat, except the surgeon was ridding the body of real cancer cells. He wasn't killing soldiers in World of Warfare or whatever. This is state-of-art technology, and our hospitals are full of it. Well, our hospitals are full of it in many ways, but they're also full of technology. So I watched this surgery, very impressive, and afterwards I was I stuck around, was chatting with the surgeon and the patient, but I couldn't help notice that after this really neat machinery, $25 million machine, the doctor was holding a clipboard. He was writing down stuff on a paper chart. didn't even have an iPad. I mean, my kids have an iPad. Same thing. All his admission paperwork was that also. It was paperwork. It was being shuffled around. When he went home the next morning, the last thing he received was what? It was a piece of paper, a script for painkillers. And when he was discharged, most important of all, he was discharged into nothing. There's really no follow-up. Nobody was going to call him or email him to see how he was doing. I told him if you had a problem, if you have excessive bleeding, call. On a telephone, imagine. How 1980s. I have teenage kids. I don't know, probably some of you do too. They don't use the phone in the way I do. They use it like this. They never phone anybody. They text, they listen to music, they check Facebook, they tweet a bit. All this to say that our health system is communicating with people in manners that's increasingly foreign to them. It's like we speak to patients now in a foreign language. Use the phone, use a piece of paper. We have to get with it. We have to communicate the way people communicate. So it's this weird dichotomy that we have. We have multi-million-dollar robots alongside paper records and all kinds of other clunky communications tools. And communication is probably the most powerful tool we have in healthcare today. It's just as important as any of our medications or machinery. And we don't give it enough, we don't pay it enough mind, the communication. So let me tell you another story, technologically oriented, because that's what I do for a living. I tell stories. So I was speaking to a physician at another conference earlier this week, and he runs a diabetes clinic. He was telling me about a patient he had. This patient was a young man, like many young men today, quite overweight, and hurtling towards diabetes, even at his young age. They were working together on a treatment plan. So a treatment plan set some realistic goals for changing his diet, his activity levels, etc. And this had been done a number of times through this young man's life already and failed. So they were filling out yet another chart. At least this time it was on the computer, because this doctor's pretty hip. Wasn't on paper. And the patient interrupted him a couple of minutes into it. He said, "Doc, is there an app for that?" And the doctor said, "No, I don't know. It's a good question." So he did some research. He went through the form and finished it. He went and did some research. And he found out that, in fact, yeah, there is a really good diabetes app. It's called BANT, as in Banting, short for Banting. And so he got this for his patient. You know, it costs whatever an app costs, $3.50 or something outrageous. And the patient loves it. He's doing quite well. He's doing better than any other treatment program that he's tried in the past, even though the program's exactly the same. But the program speaks to him now. It's on his iPhone, which is stuck to his face permanently because he's a teenager. And it beeps and tells him to do this, take your med and do your exercise. He's got it all programmed. So it's, taking the knowledge we have and just communicating it better. Now, the good part of this story for me is that it's actually the physician who adapted to the patient's needs. And that's really another rarity in our system. We always expect patients to adapt to the system. We have a system built for providers, not for patients. And this doctor, again, was a little on the cutting edge, which is good. We need more of that. So this is just an example of this huge and growing gap between our daily reality and our healthcare reality. The daily reality for people young and old is that technology is second nature. We don't go through our days without technology anymore, without the iPhone, the BlackBerry, etc. And it's not just young people anymore. All of you here are dying to look at your BlackBerries now because you're tired of hearing me. But hold off on the addiction for a few more seconds. And I've said it many times in forums like this one before. You've probably heard me say, but even pizza stores like Domino's have much better electronic records than our hospitals do, for the most part. They track that stuff because it matters to them, and it should matter to us as well. It's not all about profit. There's other kinds of bottom lines that can benefit. We all do all our banking online, I'm sure, in this room. If you have a problem with a consumer product these days, what do? You tweet about it. That's the fastest way to get action. Hey, Air Canada, you lost my bag. You suck. I've written 500 letters to Air Canada, I got no response. But first time I tweeted about my bag, I had a response back in a minute. And they actually did find my bag, which is even a miracle in itself. That's the kind of response our health system should have. And it's quite shameful that we haven't kept up. This isn't complicated stuff. 5-year-olds use iPhones. It's not complicated. Now, I know there's all kinds of excuses. Privacy is the number one, but privacy is an excuse. I'm sorry. I've heard all the arguments, and I just don't buy them. Privacy is important, but it's relative. Electronic records are still way safer than paper records. And privacy, the definition is changing. It doesn't mean the same thing as it did 10 years ago. Just look at anybody's Facebook page, and you'll have a notion that privacy means something totally different to everyone in the world who's under 35. And we have to adapt to that real world. I think health professionals and health systems more generally have to embrace and not shun social media like Twitter and Facebook. Now, that doesn't mean they have to be indiscreet idiots. They can do that in private too now, and we don't like them. We won't like them anymore in the cyberspace. Use it smartly to communicate in a manner that's comfortable with your patients. That's what it's for. Now, I keep hearing statements, and I heard this one a few times yesterday at the sessions. Well, doctors don't want to do email communication. They don't like it. They don't want to be paid for it, whatever. Well, I'm pretty sure that a century ago, doctors didn't want to give up their comfortable horse and buggies either. They probably didn't like cars because they had the nice horses and the nice buggies. So, the only response I can think of to that argument is too bad. Adapt. Get with the 21st century. You have to move on and serve your patients. So before I wrap up, there's one last disconnect I want to talk about, and I think it's probably the most important one of all. And it's the disconnect between ability and activity, or between talking and doing. And there's been many references to this as well. And I know Premier Wall is going to talk about innovation and the gains his provinces have made, financially and otherwise, with the smart use of technology. I know that because it was in the Globe this morning. Got a little taste of his speech. So. And I'm all for innovation and research, and I think it's absolutely important that we have this philosophy of innovation at the heart of it. But I think we also have to be smart enough and brave enough to follow the evidence and to implement, not have our preconceived notions. A lot of research doesn't back up what we think it should. I was reading a paper this morning that showed that telehealth doesn't actually reduce ER visits or hospital admissions. Well, that's fine. Maybe it does something else better, but let's use it for what it works. Use the evidence. We can't base health policies on wishful thinking. So the other part of the innovation puzzle I want to talk about, which I think is too often forgotten, is that innovation isn't really worth anything without implementation. The other shoe has to drop. And in this country, we do a lot more of the former than the latter. We're the land of pilot projects. Canada's probably the world capital for pilot projects. We have 1 million of them at all times. Spectacular success stories. We write them up in journals. We highlight them in the annual report of the Health Council of Canada and Infoway's annual report. Wonderful innovations. Lovely displays at conferences. Sometimes they take up a whole room. We have stories in the Globe and Mail, a whole series on health innovation. It moved my heart. It was so wonderful. But that's about as far as they go. We do a really lousy job of scaling up and of rolling out projects to the health system more broadly. That's where our failure is. It's not in innovating, it's in implementing. We do a lot more studying than doing. And personally, I'd rather see an implementation fund than an innovation fund. Let's do all the stuff we already know. Implement it now. It would take us a lot further. I can assure you that if we implemented every pilot project that's been funded and shown stellar results, we wouldn't have a technology gap. We would probably have the best health system in the world by a country mile. So how do we accelerate progress for health technology and health system more generally? Well, I think we have to break down the barriers, and I think we all know what the barriers are. So let me wrap up by reminding us what they are. What are the barriers? I think we lack clear goals for Medicare and for health technology more generally. We talk a lot about sustainability. We don't really know what we want to sustain. It's not strictly a financial issue, as Mr. Drummond said. Interest groups, I think, have way too much power in our system. They're really good at protecting their turf and promoting inertia. That's a big problem. There's not enough cooperation and sharing between jurisdictions in our country. We don't reward innovation. We fund pilot projects, but we don't reward it beyond that. We would actually reward inertia, doing the same thing over and over again. We lack political leadership. But I'm careful here. I used to blame politicians a lot more than I do now. Now I think we have to recognize the environment they work in is poisonous. It really doesn't reward them doing things better. It punishes them. So we have to change as a public, change our responses. I think we're afraid to make mistakes, or afraid to make new mistakes. We're not afraid to make the same old mistakes over and over again. That's why we have 24,000 people a year who die of medical errors. It's always the same ones. We know exactly what they are. Let's make some new mistakes. It'll be more fun. I think our expectations of quality and safety as Canadians are way too low. We have to get up at forums like this and in our daily work and say that good enough isn't good enough. But as Canadians, we are very tolerant of mediocrity. I think we have in Canada too many magic bullet fantasies. We think we're going to get that magic bullet that's going to fix everything, instead of realizing it's going to be constant incremental change is what we need. Finally, I think we've become addicted to reaction in healthcare, to having reactive actions, lurching from crisis to crisis, instead of valuing calm, orderly progress. And the provinces that do things best are actually fairly calm and orderly. They're not in the news all the time. I think we have all the information and all the money we need to act. We have all the money and information to implement the health technologies we need and to reform the health system more broadly. We have a highly developed and profitable industry of blah, 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 of which I and many of you are an integral part. And I think we have to move away from that. I think we should make a rule that at every conference like this that we attend, you must go home and implement at least one innovation you learned from another jurisdiction. We have to set some goals for ourselves personally as well as for the system. Because as it stands, we talk a good game, but we don't act near enough. So thank you for your time, and I look forward to your questions.
Thank you. It's now a great pleasure to introduce the Honourable Brad Wall, Premier of Saskatchewan, first elected Premier in November of 2007 and re-elected in 2011 with a 64% popular vote, the highest percentage of any political party in the history of Saskatchewan. He's recently tabled his 5th consecutive balanced budget. Prior to his career in politics, he was active in local business community and was involved in service work spanning local events, economic development, and healthcare recruitment. He received his post-secondary education at the University of Saskatchewan, where he earned an honors degree in public administration. He's been described as the most popular premier in the province. As mentioned, he's got a balanced budget, he's got a province that's soaring, and the only deficit that I can see is that he's cursed with the Saskatchewan Roughriders. But Premier Wall.
Well, good morning. Thanks very much for the introduction, Brian, to Richard and your team. Thanks for the invitation to be here. It's true, we have the Saskatchewan Roughriders in the province of Saskatchewan, obviously, and may I just say then, Brian, that we're recently and quite honored and humbled to be a have province within Confederation. Manitoba is still a have-not province. I just want to say for the record, we don't mind subsidizing your new professional hockey team. And should you ever get a professional football team, we're happy to subsidize that as well. There's a bit of pressure for me as a participant in this particular panel, because if things don't go well, I could get a tough column from André or a bad report from Don. Don, you don't have a report for Saskatchewan, do you?
I'm working on it.
Oh, no. A politician, an economist, and a reporter, a journalist. Sort of the rogues gallery of your conference. If we only had a lawyer and an arms dealer up front, we'd have the complete set. We were first elected to government in Saskatchewan in 2007. It was an honor, obviously, to be elected, and throughout our first 4 years, much of what we dealt with in terms of challenge and perhaps some new policy development with the great support from our Ministry of Health and other partners was in healthcare. We faced in Saskatchewan what jurisdictions with public healthcare systems face on a regular basis. We had some of the longest wait times for surgical care, for diagnostic procedures in the province. We had a dramatic shortage of frontline care, healthcare workers. Sun, the Saskatchewan Union of Nurses, would tell us we were short about 1,000 nurses. We promised to 800 new nurses in our first term. We were able to exceed that by a little bit, but I think it underscores the depth of the challenge there. We didn't have enough we lacked training seats in terms of our College of Medicine and residency positions. Facilities were badly in need of repair, and a system seemed, I think, to accept that less than good service for patients was maybe unavoidable or inevitable in Saskatchewan and maybe across the country. And of course, the healthcare budget was growing at a rate much faster than economic growth in our province. Sounds familiar. Same challenges faced right across the country and in other public health care systems. These problems exist in varying degrees of severity right across the country. And I think, as has been noted, we're all resolved to want to deal with it, to do something about it. Our healthcare system, though, is extraordinarily complex, and there are a lot of challenges from the elected side of the table, as it is from all sides of the table. And I think because of that, because of those complexities, because of the challenges that are so obvious, that there's been an abdication of leadership by elected officials, by government. I think there's a certain amount of fatalism that has crept into healthcare policy development and delivery as services deteriorated, even in the face of ever-increasing healthcare budgets. The attitude seemed to be, sure, things could be better, but at least we're not like America. And next year, we'll just bump up the budget another 8%. Our perpetual fallback seems to have been the moral superiority of Medicare and more money. The status quo has been too comfortable, I think, for various reasons in terms of health care. And as Ronald Reagan once observed, status quo is Latin for the mess we're in. Our government has sought imperfectly to try to make changes to the system with much more work needed. In that process, we haven't tried to demonize the system itself, the way it exists, or beat some sort of drum for privatization, but we've tried to make an honest appraisal of weaknesses and develop an action plan to try to improve things. In seeking solutions, we have worked hard to remove this ideological straitjacket that we all seem to wear in this country, and that maybe in Saskatchewan we wear more snugly than in other parts of Canada because of our history. We have asked challenging questions as a part of this process. Does the government need to own all of the surgical facilities in the province? Does it need to own all the long-term care facilities or build all the new ones we need? We asked questions, and that prompted the usual accusations that we were out to destroy the system, or at least Americanize healthcare in the province. And that argument, of course, presents always this false choice to the people we serve, both as patients and as constituents. The answer to the question was, of course, the government doesn't have to own the surgical clinic as long as it's provided consistently with the Canada Health Act, and that's a point that you made, Mr. Drummond, in your report on Ontario's public services. So since 2007 in Saskatchewan, we have seen, as a result of the Surgical Wait Times Initiative, a steady decline in wait times for surgery, thanks in part to increased capacity provided by private clinics invited into the province. The number of patients waiting more than 18 months for surgery, down 90%. The number waiting more than 12 months, down 79%. The number of people waiting for surgery is now at the lowest level in our province since these records were kept back in 2004. Pragmatism, not ideology, has guided efforts in the area. And so in the birthplace of Medicare, in the home of Tommy Douglas, private clinics are offering surgeries within the public system, efficaciously and effectively. Nobody's burst into flame as a result of this. In fact, I think if you asked someone in the province of Saskatchewan to choose between timeless ideology and timely surgery, they'll pick timely surgery every single time if it's part of the public system that we prize in the country. The Surgical Wait Times Initiative was born of something we did first when we came to office called the Patient First Review. We wanted to take a look at the system not from the perspective that is often used to analyze healthcare in the country, but rather from the patient's perspective. We wanted to ask the question, is the health system putting the patient first? Is the health system achieving best value and care in terms of delivery and system administration? And after hearing from patients and their families, and healthcare providers were a part of it, and healthcare administrators and others, the commissioner, Tony Dagnoni, had this to say: patient first must be embedded as a core value in healthcare and ingrained in the DNA of all healthcare organizations. He went on to say the health system has lost its focus on the patient and lost sight of the fact that healthcare is a service industry. That patient-first review then has informed not only the Surgical Wait Times Initiative, but has informed our attempt, our desire to set the targets you've heard about from the panelists here today. And we have some bold targets that we've set. One is that we will ensure all people receive necessary surgery in less than 3 months, and we're on our way to achieving that, as I've tried to highlight. We want to ensure that all people have access to a specialist and diagnostics within a week. We want to eliminate wait times in emergency rooms. We want to reduce the rate of obesity among children and youth by 5%. And we want to ensure that healthcare spending does not outpace economic growth. And when we announced those targets, a lot of eyebrows were raised, including by the health minister and most of the members of the cabinet. It's interesting, isn't it, that these targets would shock people in our province, especially in the healthcare system. Because I think what we have had is a paucity of targets and goals in healthcare, and I think it is the fault of those of us in elected positions, because I sense that the healthcare providers, the ministries, the administration would like to set these goals and then achieve them. It's interesting that people would be most doubtful of the goal where we want to provide immediate care in an emergency room. In an emergency room. People are doubting the fact that we can set a goal where you don't have to wait for emergency care. We know that this happens in North America. We know that it happens around the world, where you can go into an emergency room and not wait. And it's not Shangri-La, and it's not some fictional place. It's happening today. And so why in Saskatchewan, when we learn about how they're achieving that and then apply those techniques to our own situation? We, by the way, should also be aiming high nationally with goals. And maybe the federal government, with its maybe retrenchment from healthcare in terms of the transfer issue, is not going to be the leader in this, but provinces can be. Provinces can be in terms of setting some of these goals nationally. As has been noted, Prince Edward Island Premier Robert Giz and I have been asked by the premiers to chair the Healthcare Innovation Working Group, which was created by the Council of the Federation last summer. I think André and others have, well, André, I think, has taken us to task for the Innovation Working Group, not because André's a jerk, because he's not, but because he, like many other Canadians, are getting tired of all the committees and the commissions. And now there's going to be a working group of healthcare ministers chaired by a couple of premiers, and when are we going to get on with the action, as André quite rightly pointed out at the end of his remarks. So let me give you some hope about that particular process. First of all, we are going to listen carefully to healthcare providers in the country as we embark on healthcare innovation. And we've already met, I talked with Judith here this morning, we've met with the CNA and the CMA and HEAL, and we're going to continue to engage those on the front line so we can get this right in a report back to premiers this summer. Here's the other reason why there might be hope for results from this particular working group. The last time the premiers of Canada said we're going to have ministers work on a project, but it'll be chaired by 2 premiers to drive that process, to make sure we're making progress and that there are actionable items coming from it, was on the Agreement on Internal Trade. And I was just elected when that process was winding up. A couple of premiers chaired the economic ministers of the provinces, and guess what? There was a labor mobility deal, a pretty historic labor mobility deal that came from those AIT efforts. And so when we met at COF this last summer, it was Premier Charest who said, why don't we use that same model in terms of healthcare innovation and a working group of the health ministers? And that's exactly what we're doing. We're starting with 3 specific areas, and we will deliver actionable items to the premiers in the summer meeting around scope of practice, around clinical practice guidelines, because Don's right. I mean, I don't know why we're not cooperating more, maybe not just for cover, but in the interest of best practices and best care and efficiency in the system. The third one, by the way, is human resource management. That's the other issue we're going to focus on, and provinces better coordinating with each other as we deal with the huge human resource tasks of healthcare delivery. 70% of the healthcare budget in the province is of Saskatchewan. Human resources, the numbers are similar across Canada. So the work is going to be important, not just for the results that it'll deliver, but for what's next. Because if we get this right, and the premiers like what was reported to them by this group, I think they will be tasked to do some more work. And obviously, e-health is at the top of the next list of items, and it should be. It's one thing to set objectives, it's another to meet them. How do we do this in healthcare? In Saskatchewan, part of the solution is implementing the lean process in all health regions at the Ministry of Health. I'm going to spend a little bit of time on it, if I can this morning. I'm sure many of you are familiar with lean and the story of Toyota and its exporting of its example and model to many other companies and organizations around the world. Through lean, employees are empowered to identify activities that don't provide value for customers, patients, and engage in a process of continuous improvement in enhancing quality and safety. Activities that don't provide value include searching for supplies, filling out forms incorrectly, taking extra vials of blood, stocking just-in-case inventory instead of just-in-time inventory, ordering unneeded tests. The introduction of lean started in Saskatchewan by the then CEO of the Five Hills Health Region, headquartered in Moose Jaw, Canada, by a fellow by the name of Dan Florizone. We've asked Dan since, in 2008, to obviously join us in leadership as the Deputy Minister of Health in the province, and working with the Health Minister in Saskatchewan, Don McMorris, the longest-serving Health Minister now, I think, in the province. He's asked for a break, by the way. Dan has been a relentless advocate for enhancing patient care through systematic improvement in processes. Don and Dan have provided leadership, but both would be the first to tell you that it's been the frontline workers. It's been doctors and nurses and healthcare workers that have really made the progress in terms of lean. One of them is Patty Curtis. She's a nurse and a clinical educator at the Regina General Hospital. She works in diagnostic imaging. She was involved in a lean process with the goal of reducing the number of canceled MRIs. At first, Patty thought the problem was obvious. The ambulance teams couldn't keep on schedule, she thought. That was the theory. But over time, she and her colleagues discovered other issues. Doctors weren't filling out forms properly. The forms were badly designed. Patients who could travel to the hospital by car were being transported by ambulance. Specialists would forget to tell their patients about appointments. Weaknesses were identified and stronger performance followed. The Regina Qu'Appelle Health Region has now reduced canceled MRIs from 12 per week to 1 per week. That's allowing the region to do 650 more scans a year. Remember, our objective, one of our goals is getting to diagnosis a lot quicker than we are today. That's a 7% increase in productivity, and applied across the province, a 7% increase in productivity means 2,600 more MRIs a year. That's important. That's a serious number. That is worth pursuing. Here's some other examples quickly. The Prairie North Health Region has reduced overtime costs of missed meal breaks by $200,000. That's a 95% reduction. Province-wide, other attendance management initiatives have saved $18 million to date. Some would say, well, what's $18 million on a $4.9 billion budget? I would say it's $18 million on a $4.9 billion budget. It's 18 kilometers of highway. It's $18 million worth of less debt. It's a lot of things. Through infection and prevention control efforts, the Saskatoon Health Region has reduced costs by $1.37 million. That's 28%. The healthcare system is saving $10 million a year by improving the inventory management, the discard rate for units of red blood cells, and more than $1.2 million a year through effective management of vaccines. At the Saskatchewan Cancer Agency in Saskatoon, wait times between the patient's first appointment and CT scan have dropped by 92% because of lean. Application of lean design in the planning of our new children's hospital, which we are in the process of planning for and will begin construction on, has cut the overall space requirement by 16%. That'll save millions of dollars. The Releasing Time to Care initiative is freeing up healthcare providers to do their job in about 90 wards across the provincial health system. And last week there was a report out about the relative success we've had in terms of recruitment and retention of frontline healthcare workers, including nurses. And a specific item that was cited wasn't all about money. Releasing time to care was important for our nurses in the province because it allowed them to do more of what they wanted to do in the first place when they went to university, when they went to college. And they cited it as a reason they would want to stay in Saskatchewan. Those are just a few examples of lean. We're going to take another big step with respect to lean coming up here. Dan has told me what it's going to cost, so I'm pretty sure we're going to do it anyway. We are going to make that investment. And by the way, more on that in a moment in terms of that initial investment. But we are going to continue with this process because it is resulting in better value and better care. It's not always about saving money, but it's about one or the other, and usually it's about both. The adoption of information technology is also crucial. I'm not going to spend a lot of time on it. Obviously, anybody in this room knows more about it than I do. But I do want to give you some advice. We know, by the way, that this is an important part of innovation in healthcare, and I do think it'll be a part of the next tranche of work that the committee does, the Giswall committee might do with the health ministers across the country if premiers ask us to. But I thought you might be interested in how you could ensure that governments are more readily willing to invest in e-health initiatives. Think of it this way. Cabinet ministers, cabinets across this country, on a fairly regular basis, get proposals for new IT systems, a new land title system, a new citizen-centered service system, new softwares needed here. And after a while, your eyes glaze over, because it's hard to see immediately as elected people dealing with with a massive agenda, it's hard to see the payoff. It's easy to see that when you're talking about a highways budget. It's easy to see the payoff when you're going to build a hospital, where you're going to add this service or build a school. But the area of IT is different. And all I would advise, all I would counsel for those of you who work with us elected people and our short attention spans, I just advise that you make this as real as possible. These lean examples do that for our government. We have these examples now because of Dan's leadership, and so when we do go back to Cabinet for more investment in the next phase of lean, we're going to be successful because of the examples I was able to share with you and that we share with the rest of the province, and so that there is some political impetus as well for these kinds of improvements. That is lacking around e-health, I would say, to this room. And so, at least in our province. We have a great CEO in Susan Antosh. I think she's at the conference. I would just advise everybody that if we can make the case to our elected people in this country about the effects, the patient-first effects of e-health, you'll find, I think, the investment will be forthcoming. I just want to leave you with two of what I think are the biggest threats to healthcare innovation and healthcare improvement in our country, and I'll deal with our province. The first one is a lack of fiscal probity. If we are not careful and mindful of the fiscal health of our respective jurisdictions, it's going to be obviously a lot more difficult to make additional investments in innovation. All these pieces of innovation that will work, lean included, cost a lot of money. There's an upfront investment that's needed, and so there needs to be the fiscal capacity to do it. You need health ministers and health professionals in the health sector providing leadership in terms of the deployment of health resources, with all due respect, not finance ministers. You don't want to be making health decisions because you've gotten a report from Mr. Drummond that says, here is an imperative that you have to deal with now. Fiscal probity, fiscal discipline today is going to give us the chance in the room to make the important new investments we need to make, one time some of them, or at least short-term investments to make long-term progress. And finally, the biggest threat to healthcare innovation and generally the state of health in the country, I think, is if we lose our focus on the economy. Isn't that the number one determinant of people's health? Is their economic well-being, is where they are at financially and economically. And so we in government need to make sure we are focused on a growth agenda. We know that the dividends of that growth agenda are the chance to invest in the kinds of things that we're talking about today. We probably, as elected people, should have been doing this a long time ago, what we're trying to do imperfectly in Saskatchewan today. There's an old rancher in southwest Saskatchewan who reminded me once, he told me, the two best times to plant a tree are 20 years ago and today. Well, if you're from southwest Saskatchewan, you'll understand the importance of that statement. We weren't doing this 20 years ago. We have no choice but to do it today. And we're going to be relying on all of you to help us along. Thanks for your time this morning.